Welcome everybody. Just going to give a few more seconds to allow people to join. We've got lots of people joining today, which is wonderful. Welcome. Still got some people joining now, so just going to wait a minute or so. Hi Julie, how are you?
Hello, yeah, very well, thank you. Hello everybody. Thank you for joining. I can't see myself, but I'm just smiling into my camera, so hopefully that's okay.
It's a lovely smile, Julie.
Oh, well, the slides are
people.
much more important than me.
Wow, goodness, lots of people joining. Sorry, I will kick off in 1 minute, just making sure everyone can join that wants to. Perfect. Right. Okay, well, welcome everyone. Thank you for joining our final webinar from our Exploring Eczema webinar series. Today we'll be learning about facial eczema. I'm Eleanor Martin, I'm the Health Content Lead at National Eczema Society, and today I'm joined by Julie Van Onselen, our lead speaker of the Exploring Eczema webinar series. National Eczema Society is a UK charity that provides support and advice for people affected by eczema. Alongside our wide range of information and advice, we use our collective voice to raise awareness of eczema, progress research, and campaign for better care. We've been working to make life better for those with eczema for over 40 years, and we rely on voluntary donations to do so. We will be recording today's session, so you'll be able to watch it back afterwards. But not to worry, all participants' microphones will be muted and cameras will be switched off. Please change your screen name to anonymous if you don't wish for your name to be visible in the recording. There will be an opportunity to ask questions at the end, and you'll be able to do this by using the Q&A chat feature. So feel free to drop any questions that you have throughout the presentation in there, and Julie and I will aim to answer as many as we can at the end of the session. Today we're joined by our lead speaker, Julie Van Onselen. Julie has worked with National Eczema Society as a clinical nurse advisor for over 20 years now, providing support to thousands of members of the eczema community. And she also has an impressive 30 years of experience working, caring for those with eczema in the NHS. So over to you, Julie.
Thank you, Eleanor, and good evening, everybody. It's a beautiful sunny evening in Oxford here, and I hope it is where you are, and a welcome. So this is quite a milestone. Eleanor and I, over the last, I think, 8 or 9 months, have done 8 webinars. The Exploring Eczema webinar series has been very successful, and thanks to you mainly for joining, really. And I think it's been really helpful. Previously, I worked on the helpline and may have even spoken to 1 or 2 of you. And of course, we were helping a smaller number of people. The good thing about the webinars is I do feel we're doing a lot more now at the Eczema Society, maybe for the greater good. So by giving this information via webinar, we can help a lot more of you. So if perhaps this is your first webinar, there are 7 more to even look again in the series. And facial eczema is the last webinar of this series. And we did a lunchtime session on Monday. So this is the very last one. The series will come back. We're not sure when, and we will be doing more interactive sessions in the future as well. So Eleanor kindly introduced me, and here is a little bit more information about me. I'm very passionate about my work for support groups, and I officially work for the National Eczema Society, but I work for some other support groups as well. I have a mixed role where I work for charity, clinical, and also teaching and education. And I'm really passionate about trying to improve dermatology care through education and through support for people with skin conditions. So tonight, what does the webinar cover? Well, we're really going to focus on the face. Last time we did a webinar on contact dermatitis, and there are some crossovers because often severe facial eczema that isn't responding to treatment can sometimes be a contact allergy. And last time we focused a little bit more on hands. So tonight it's about the face. And judging by the popularity of this topic and by the number of you here, I hope it will be really, really helpful. I mean, first of all, I must say, I think facial eczema is incredibly distressing. It's the one area of the body that is your window to the world, the one area of the body that is very difficult to hide. If you have facial eczema, you immediately perhaps have a visible difference that can cause, a lot of distress, as well as, the physical symptoms of eczema, which are also distressing to cope with as well. So what we're going to cover tonight is what and what isn't facial eczema. Because I think that's quite important, because there might even be some of you who have a misdiagnosis and maybe even have a mixed pattern on your face. The interesting thing with the face is that sometimes you can get more than one skin condition on the face. So I'll explain that. Principles of eczema treatment for the face, and we'll include around the eyes, and we've even got some information on lip eczema. Facial skincare, makeup, sunscreen, and how to protect and manage facial eczema in the long term. And then a little bit on coping with visible eczema. The one thing we're not going to include is any side effects from advanced therapy, because actually that goes into another subject area altogether. But of course, there are the principles that apply as well. So when we do these sessions, we always think about common questions, and the common questions really have always evolved really from the history of the helpline. And when I was on the helpline, a lot of people asked me about different types of facial eczema. And that was quite interesting, because there are a number. So how do I know if I've got a different facial skin condition, or even if I've got a combined skin condition, for instance, acne eczema, eczema rosacea? That's quite important. We need to get the best treatment that's going to work for both conditions and not exacerbate. So what is then the best and safest way to treat facial eczema? What skincare products, sunscreen and makeup can I use? And what are the cautions about treating facial eczema around the eyes as well? People really worry about the eyes of all our fact sheet. I think facial eczema and eye eczema are the two most popular. So atopic eczema or atopic dermatitis, of course, can affect the face in any age group. Commonly, when atopic eczema develops in babies, generally between 3 and 6 months, the face is often the worst affected. The little babies' faces can be red, can be sore, and the rest of the body sometimes is a little bit more generalized. Of course, there's a lot of irritation with dribble, teething, food, etc. And we'll talk a little bit about that in another slide. But actually, eczema can affect on the face can be an area of eczema for any age group. And sometimes if you've had eczema as a child and actually your facial eczema becomes a lot better over time, indeed, you can then have a period without facial eczema. And then as an adult, lo and behold, the eczema can come back to the face. I always say with eczema, there's sometimes no rhyme or reason for how it flares and how it then settles or how it comes back. Now, one thing which is an important red flag on the face, and I put this in straight away in the first slide rather than a complication, is a type of eczema called eczema hepaticum. And this is actually an eczema that is particularly stimulated by the herpes simplex virus. It generally occurs for people with eczema on the first introduction of the herpes simplex virus. And what happens is you get eczema that is actually very, very sore, very painful, blisters, and it is sort of forms in small clusters of blisters. And people actually feel unwell with it as well. So it's really important, if you do have any signs and you're unwell and you've had a sudden eruption of blistered skin on your face, that you immediately seek emergency same-day treatment, because that is a nasty complication of eczema and needs to be treated with topical viral treatments. So now a very common sort of eczema called seborrhoeic dermatitis. Of course, we see this form of eczema in babies, and sometimes in babies we give it the name cradle cap because we often see it on the scalp. In adults, seborrhoeic dermatitis is similar. It's seen in the hair-bearing areas, which have the most sebaceous glands. That's where it gets its name from. And you tend to get greasy scale red patches. Interesting enough, it's the least itchy form of eczema. So you see it on the eyebrows, the scalp, the nasal labial folds, we call it, and you see these sort of yellow greasy scales. It actually affects 3% of the UK population. It can sometimes occur alongside atopic eczema. It can sometimes occur by itself. And it really is a sensitivity to a yeast on our microbiome called the melisma. So it's something that is sort of stimulated by something already on our body. It's more common in men in sort of young adulthood, 18 to 40, HIV and Parkinson's. So you might see it in older people with Parkinson's. If someone has very severe seborrheic dermatitis, sometimes that can link to HIV, and people with Celtic skin. It's another type of eczema that coexists with another condition, rosacea. So sometimes you see them together. And treatment really is the mildest steroids for a short period of time. So we generally use a hydrocortisone, a very mild steroid, often combined with an anti-yeast from the start, and then maintained maybe with just an anti-yeast ointment. We'd use anti-yeast shampoos as well. But the other really interesting treatment, which we are going to talk about later, are the topical calcineurin inhibitors, so Protopic or Elidel, to give them their trade name, which are so useful for long-term and ongoing maintenance of any facial eczema. So now let's move to the next slide. A little bit more about babies and this irritant facial eczema. So one reason why facial eczema can be so difficult as a baby is because often there's a lot going on the face that can irritate. And you can see this sweet baby self-feeding. So these are foods which are sort of citrus or highly coloured, tomato ketchup, etc., can cause an irritant dermatitis. So this is not food allergy, because food allergy you would see different symptoms. We had a webinar which covered food allergies, but you'd see more sort of swelling, a difficult eczema, almost hive type form of eczema. And of course, infants can be messy eaters. And if you've got some atopic eczema on the face, it can then combine with an irritant dermatitis and make things a whole lot worse. So the top tip is to always use a greasy emollient generally as a barrier around the mouth or around where the food's going to be deposited on the face. With this little one, it's going to be everywhere prior to meals. So you've sort of got a physical barrier. And then after meals, remove any food residue with a damp cotton pad that you need to literally spread the emollient onto it. At all costs, avoid any wet wipes. It's very tempting when you're out and about, but wet wipes will actually cause more irritancy and actually drive the eczema. So contact dermatitis in adults, and we covered this in our last webinar, so I'm going to be fairly brief on this, but just go through some of the key points. And it's really interesting. A lot of people have eczema on their face as a baby child. It then gets perhaps sometimes better in older children, teenage years, and lo and behold, it comes back with a vengeance on their face. And sometimes people wonder why. It can often simply be an allergic contact dermatitis. We know it's much more common to appear on the face and the eyelids and indeed the hands. And actually, this needs to be properly diagnosed by referring to a dermatologist and having patch tests. And there are many, many culprits. It may be cosmetics. You can see the nails up there. So it can even be a nail varnish or acrylic nail allergy. Sometimes it can be to sunscreens. Hair dye is a big culprit. Occasionally, even some additives or preservatives, etc., in topical treatments. I should say ingredients, really, because it's not always preservatives. Symptoms in the spring and summer would always consider that. So this time of the year is classic, a spring stay with very high pollen and a lot of blossom on the trees. It's amazing how many people with eczema and atopic eczema suffer from eyelid and eczema around their eyes at this time of the year, purely because it is a pollen allergy. If you tested everybody with eczema, everybody would have some allergy to pollens and hystus mites. So again, you know, environmentally in the home, if you're sleeping with old pillows, maybe without allergy covers, you know, consider buying new washable pillows or using covers. It sometimes can even be related to a new hobby or occupational substances with people in more manual labor, maybe. And again, you can have atopic dermatitis, seborrheic dermatitis, and you can also then develop an element of contact. you're building a picture of how the face is really actually quite complicated, because actually it's a one area where you can have more one type of eczema going on. And photo contact, again, is something very common in the spring. And this is an irritant or toxin allergic reaction that occurs when chemicals are applied to the skin, then exposed to the sun. It also can even occur with medication, maybe even some things like diuretics, water tablets, or tablets for heart disease and things like that. It can occur with some sunscreens and particular products containing tar, because tar is a photosensitive. Fragrances as well can have a photo contact allergy, insecticides as well, and even plants themselves. Sometimes when people go out gardening in the spring and you've got certain plants like giant hogweed, rhododendrons, chrysanthemums that start to flower, you can also get what we call a phyto contact, which is the effect of plants touching plants with the sun, causing a contact. We did talk about that in the contact dermatitis lecture if you're interested. So, of course, patch testing is, sorry, there's a typo there. I thought I'd used it, is used. So that's wrong. Patch testing is used for diagnosing allergic contact dermatitis. It is not used for irritant dermatitis, because basically if you have an allergic contact dermatitis, you have what's called a type 4 hypersensitive reaction. So whatever's causing the dermatitis will sensitize on your skin. And that's why it's really important to do patch testing, because you can have a variety of different patches applied to your back. You do need a clear back, and it's called a proactive test. And if there is a contact allergy, you will get a skin reaction, and then you can diagnose and find out. It's one of the few areas of eczema where we can say we can perhaps find a cause for your flare of eczema. Now, it's really important that there are some types of conditions that are not eczema and actually are going to be made a whole lot worse with eczema treatment, particularly topical steroids. So I just want to go through two other conditions that sometimes, if they're wrongly diagnosed as eczema and you're prescribed even mild topical steroids, it's going to get a whole lot worse and become very irritated, maybe even sore, and inflammation may even cause burning. And sometimes, this is thought that topical steroids are causing it, and then people who have eczema elsewhere may stop using topical steroids elsewhere. But this is purely on the face, and it's really, really important to tell you about these two conditions. So the first one has a name that I really dislike because it's called perioral dermatitis. It should be called perioral eruption. The reason it's called dermatitis is a descriptor of looking like eczema. It is not eczema, not dermatitis. It's actually related to acne or rosacea. So you would never use topical steroids on this one. It may even be caused by topical steroids, even at a distant site, hands not being washed, or even inhalers. So you should always wash hands after application elsewhere on the body. And the treatment for this is along the acne line. We would actually prescribe an antibiotic called limacycline for 3 months. You get classic sort of red, what we call papular eczema around the mouth, sometimes sides of the mouth, sometimes around the nose, but it always tends to be in this chin area. So have a think. If you think, this is eczema and you're not treating it at all, it may be a completely different condition that needs a completely different treatment. So rosacea also is a red face that's not facial eczema. Again, if you've got a diagnosis of eczema, sometimes a healthcare professional may think that if you've developed red, rosy, slightly sore, stinging cheeks, that it must be eczema because that's your diagnosis. It's not. And again, steroids will play havoc and make it a whole lot worse. It's a vascular facial condition thought to be caused actually by damage to the dermis. So this could even be from having bad acne when you were younger, sunburn, or even other skin conditions. But mainly it can be associated with migraine. So if you have migraine and these red cheeks, you may well have rosacea. You can have two skin conditions at the same time. So you could have rosacea and you could have facial eczema. So what we have to do is we have to treat the eczema with a treatment that's not going to be exacerbated and make the rosacea worse. So this is again when we use the topical calcineurin inhibitors. So rosacea is more likely to affect people who are sort of 30s, 40s, 50s, but then a lot of young people and people in their 20s or even beyond their 20s can also have eczema and acne together. So that's really, really common. And what you have to do, again, is adapt to treating the acne and treating the eczema. So lighter emollients are preferable as acne skin is generally more greasy. So you may have drier eczema on the rest of your body, but your face may be greasy. So you need to adapt to use a lighter moisturizer because you don't want to clog the pores because that will make the acne worse. Again, you shouldn't use topical steroids if there's any sign of acne. Topical steroids will make acne worse. And it's important to treat acne and eczema at separate times of the day. So again, for eczema, the topical calcineurin inhibitors are the most ideal treatment. They work very well with acne. And with acne, you might consider a topical treatment. And some topical treatments have antibiotics, retinoids, and another ingredient called benzoyl peroxide. Benzoyl peroxide actually is very drying, very irritating. So sometimes I find people with eczema don't get on with it as well. So you may be better to have an antibiotic retinol combination, which might be sort of kinder to eczematous skin. Otherwise, I would start slowly with the acne treatment that may irritate the eczema. Maybe use it for an hour a day, wash it off, maybe use it on the inside of an arm. So when we look about treating facial eczema, again, it's similar principles to what you've heard before, the bland, non-fragrance medical moisturizer for washing and moisturizing. Try not to wash with water alone, particularly in hard water areas, because water alone can still raise the pH of the skin to 7.5. And that's why we know soaps and detergents are an absolute no-no, because they will raise it even to a higher alcohol level and actually destroy or distract the skin barrier. So you need to treat the inflammation. Now, if you have facial eczema and it's facial eczema, there are no other conditions. A mild or moderate topical steroid, depending on age and severity. So for a baby, definitely mild. Maybe for an older child with difficult eczema, and certainly for an adult, you may need a moderate. The key thing is the short treatment burst. So a 2-week burst, once a night for a week, then every other day. Never use anything stronger than a moderate on the face. So never use your potent steroid or never use your very potent steroid. But you may be advised this by a dermatologist. Once you put out the fire, you need to keep control. And remember, the face is very prone to irritants because there are a lot of irritants that our face is on show and it's in the environment all the time. So the topical calcineurin inhibitors are absolutely ideal. They have no risk of skin thinning and they're absolutely best for long-term maintenance. And avoid the irritants as well. And be aware of your seasonal changes and get any allergy diagnosed, particularly contact allergy. So now we come to the more difficult areas. So eczema around the eyes and the eyelids is a really tricky area. Some people really, really worry very much about treating this area. They absolutely worry about steroids. That's completely right. And as I say, the mild or moderate topical steroid will be fine, but never potent or strong or very strong. Keep the facial skincare just simple. It really is best not to use too many sort of cosmetic washes. They often contain detergents and perfumes, and even your own skincare. You might be better, if you're having a flare, to just keep things really simple. Just use a few products, your moisturizer for washing, an emollient. You might need different types. You don't necessarily need to add in serums and things if your eczema's flaring, but you again, I would always say just test on an inner arm or test for an hour because some of these things can flare. Again, the topical calcineurin inhibitors are just ideal for eyes and eyelids, and I would actually move people onto these pretty quickly, actually almost actually would almost treat first with those and not with steroids for eyelids. You can also get blepharitis, which is sort of crusting and stickiness of your eyes caused by inflammation and swelling. So you need to literally just lie with a warm, soft muslin flannel on these eyelids and then just gently clean the crust away. And in that way, you know, blepharitis, inflammation of the eyelids can complicate facial eczema. Blepharitis also causes dry eye. So again, eye drops that are not perfumed and are preservative free. So again, you can ask your local pharmacist, are really useful. And a lot of eyelid eczema is exacerbated by rubbing. So top tip for children and even adults, if you're going to apply your once daily topical steroid, certainly for children, always apply it when they're fast asleep. I know that's not always easy, but if you apply it gently with a cotton bud when a child has moisturized before bed, that the topical steroid will stay on and do what it's meant to do. If you apply it when the child's awake, they will just do this and you just won't get any treatment. So that's really important. And you can also use a cooling eye mask at night as well. And that's really useful because that prevents rubbing in the sleep. And we do know that a lot of damage to the skin is done by itching and rubbing when people are asleep. And again, eyelid eczema can often relate to contact allergy, so ask for patch tests. So lip eczema is another area. It's often much more common in children, sometimes in young people if there is anxiety, and basically it is an irritant dermatitis. Although sometimes it can again be a contact dermatitis, maybe for adults or older teenagers from lipstick. It may even be a lipstick allergy. But the main thing is there's a constant feeling of dryness and a little tongue comes out and licks around the lips. Of course, that makes the area more drier. It disrupts the skin barrier. So, and again, this can even occur in the sleep. So I think a nice sort of bland, nice greasy lip salve in the day. Make sure if it's sunny, you've got one that has SPF in it. And at night, a really thick smear of a nice greasy ointment. A waxy ointment is better than a slimy ointment. So something like Hydromol or Cetrimide ointment, something like that. Something with a solid ointment rather than a sort of more sort of liquid paraffin based. Mild to moderate steroids again can be used on the lips as well as the tacrolimus as well. So we've talked a lot about tacrolimus, Elidel, and topical calcineurin inhibitors. And we covered a lot about steroids in previous webinars, but perhaps we haven't focused as much on the other treatment, which really is very ideal for facial eczema. And I will move patients onto this treatment pretty quickly because I know that if you're going to run into any problems with steroids, particularly with skin thinning, the face is a bit of a danger area just because our skin is much thinner on our face and the most thin on our eyelids. It was the opposite with hands and feet because it's a much thicker skin, so it can tolerate stronger steroids for longer. So topical calcineurin inhibitors, first of all, are not steroids. They are immune suppressant or topical treatments that act on the very complex skin immunity and try and turn the cytokines which cause inflammation to not cause the redness and the flare. So they're really quite clever. They sort of target eczema pathways. There are two types, a cream called Pincrolimus or Elidel, and this is really useful because it's actually licensed from 3 months of age, so really helpful for those babies with difficult facial eczema where parents really worry about using steroids at all. So great, you've got something alternative that's non-steroid and might well help a lot. And also, you know, they are licensed when TCIs are inadvisable or not possible, and they would be inadvisable for anything more than a short-term treatment. Tacrolimus or Protopic comes as an ointment in 2 strengths, 0.3 for 2 years old onwards and 0.1 for 16. And again, people who are not adequately responsive. So unlike steroids, we don't have a step up, step down sort of ladder system. They tend to be prescribed on age and formulation preference. So a baby, you definitely prescribe Elidel, but then you might have an adult who prefers to use a cream. And tacrolimus, again, is prescribed in the 2 strengths depending on age. It's important that they can be used for flare treatment. So if you don't want to use steroids on your face, you can use them from the offset. But to be honest, if you've got quite a severe flare, it's much better to take out the fire with the steroid first until the eczema is clear. The great thing is they can be used for long-term maintenance, and this is where I find them so useful. So you can use them intermittently twice a week in divided days. Apply to the area that was affected by eczema, because hopefully the eczema may have gone, and it will actually keep the eczema at bay. You do need a gap with emollient. We generally work on the sort of 20 to 30-minute gap. Protopic has a sort of license that says it should be 2 hours. Purely when they did the research, they involved a 2-hour gap, which isn't always practical. But again, if you're treating a child with eyelids, again, you can just pop on the treatment as you're going to sleep. Now, you may have read of some cautions and side effects with TCIs or topical calcineurin inhibitors. Really important to go through. Now, the first thing is they would cause tingling, even burning. This is not an allergy. This is to be expected. Nearly everybody who uses them does feel some tingling. It's something that the skin just has to sort of get used to. So you can start slowly on the inside of the arm or use an arm wash off and build up to once or twice a day. If you're actually treating a flare, it is a twice a day treatment, unlike the once a day topical steroid. And if you're using for maintenance, you can just use once a day on that sort of divided dose. Now, you shouldn't use if you've got a skin infection, absolutely not if a cold sore, because they may not act well with infection, and they do have a bit of photosensitivity. So again, you need to use the sunscreen. So you should basically then have another gap between applying the TCI and then applying your sunscreen. If you're an adult and you're drinking, you can get some flushing with alcohol. The key thing is that when they first came out, they had quite a scary warning triangle around cancer and lymphoma, and this has made people very wary about them. The good thing is that actually this was completely dismissed with a very large study, systematic study of thousands of patients reviewed over 20 years, and they found there was absolutely no increased risk of skin cancer or lymphoma. Now, you might say, well, why did they scare us in the first place? The reason is that these topical treatments were developed from oral tacrolimus, which is used very differently in huge doses when people have organ transplants to prevent organ rejection. So they had to be cautious, but it's really great. And I think that is really good news because people can be fairly relaxed about using them and using them long term. So when we look at just general facial skincare, my little mantra is clean, moisturize, protect. So protect is sunscreen, cleanse with a moisturizer, moisturize your face after you've cleansed. So, the old adverts always used to be for people who are my sort of age, maybe cleanse tones moisturizer. Toning isn't that good really because it's a drying agent and it sort of tightens your skin and it doesn't really have much sort of need for people, certainly with eczema, because it's just going to irritate, as are exfoliating scrubs and certainly soaps and detergents. Cosmetic moisturizers and face cream often contain a lot of extra ingredients and extra added things. So it really is to try and keep your skincare as simple as possible. And as we know, children do not need face creams. In fact, there has been some horrific reports about children using face creams. There's a lot of bad marketing at the moment, focusing children to brands that look quite childlike. And in fact, there have been some really nasty reported cases of children using vitamin A, retinol, and damaging their skin. Or having absorption problems. So we need to sort of tell our teenagers that, you have your skincare routine, but you match it with your eczema. Otherwise, your eczema will be worse. Essential oils, they feel appealing. Something with essential oil, you might think, well, it's a bit like this label. It's labeled natural with essential oils. You might think, well, that sounds ideal. Interesting enough, there are as many contact allergies with essential oils as there are with perfumes and fragrances. And the most common essential oils to cause allergy are ones with linalool and limonene, which is a sort of lemony flavour. So it's probably best to avoid that. And things that say dermatology tested or hyperallergenic often aren't. Other tips is you don't really need a separate makeup remover. Again, they've probably got more ingredients and can be irritating. You can use your own emollient. And if your face is very dry, you might want to just have a nice rehydrate at night. Now, I think it's important to talk about beauty and aesthetic treatments because this is something that people either enjoy or want to have. They may be concerned about their appearance and they think it might help. So it's important to have a look and just tell you what wouldn't be recommended, because what would absolutely make your eczema worse. So hair removal, avoid waxing and debilitary creams. They will make eczema worse. Dermatologists would say do not use dermal fillers. Don't use chemical peels, particularly if eczema is active. They will make it worse. And dermabrasion is just too abrasive as well. The same for sort of micro needling as well. It can be quite abrasive. Interestingly enough, Botox is considered more safe for people with eczema because it's a single injection, but it's not recommending that it might help eczema. It's generally used for deep wrinkles. Eczema hair removal, you're better to thread, pluck or shave, but avoid shaving if you're flaring. And facials, choose gentle fragrance-free products and techniques. Try and avoid facials that use steam or heat or over-exfoliation. That might make it worse. But I'm sure there's a lot of beauty therapists who are very empathetic to people with eczema and can offer you some nice relaxing treatments as well. So makeup, look for products which are hydrating and soothing on skin. So hydrochloric acid, sort of glycerol, etc. They're sort of humectant ingredients. So you might find those in some foundations. To be honest, a mineral foundation, so a foundation which is a packed powder based is probably a little bit better, as are powder eyeshadows, which are more zinced based. You can use your emollient as your actual primer because, again, primers can contain fragrance, and you want something that's really is saying or advertised to be gentle on all skin types. Again, that labeling isn't necessarily always what it says. But do avoid fragrance and, as I say, remove makeup with emollient. I think a really, really key thing for eczema is just to wash your makeup brushes twice a week, 3 times a week even. The thing is, when you have eczema, you have a lot more Staphylococcus aureus on your skin, and that Staphylococcus aureus can sort of spread. It can actually cause a super antigen effect and make your face flare. So actually, by washing brushes, you're reducing the spread of those little microorganisms that will have been picked up in your brushes. And if you suspect that any of your makeup is an irritant or allergen, just stop using it. And then perhaps reintroduce your makeup brands one at a time. You may even be able to do that as a sort of self-patch test to find a culprit, but generally you need patch testing to find the actual ingredient, because you'll find that ingredient will also be contained in lots of other things. So hair dye, PPD allergy. So PPD, I won't attempt to say it, but it's the chemical used in hair dye and henna tattoos. So, you can get some really nasty allergies from these, and henna tattoos tend to be temporary, but they still can cause a nasty reaction. But hair dye allergy is really nasty. It generally affects the sort of skin around the scalp, and it generally then causes a very sore red eczema on the face. So again, you might have really difficult burning red eczema, and you may be getting your hair dyed regularly, and you may well have an allergy to the hair dye And that's the problem. And that's why treatment isn't working. So I think, when we build the picture of facial eczema, it's much more of a jigsaw than other parts of eczema on the body. And, it can cause nasty swelling and blistering. And, again, it might be that people think, oh, it's my eczema or it's something I'm using on my face, but it could be what you're using to dye your hair. And it can also sometimes cause generalized eczema over the body as well. So sunscreens are really important. We want to avoid getting skin cancer, but finding one that suits you and doesn't irritate when you get eczema is another challenge. So when you're looking for a sunscreen, there are two types. There's a chemical absorber, which actually absorbs UV radiation. Again, it tends to be a bit more ingredient heavy and can sometimes be more irritating for someone with eczema. A mineral-based UV sunscreen has a reflector, and it reflects back light with mineral-based ingredients, and mineral-based ingredients tend to be kinder to eczema, such as titanium dioxide or zinc oxide. And most people with eczema prefer mineral-based sunscreens, but it's just like emollients. What suits one doesn't suit another. It's really important to apply the emollient first, have a gap, and then apply the sunscreen. You don't want to do it the other way around, because what happens is the sunscreen almost acts as and can cause a sort of frying effect in the sun, and maybe can even cause you to burn. I mean, ideally as well on hot days, if you have eczema and an irritated face, wear your wide brim hat, try and stay out of the sun when it's very strong. And your SPF should be 30 to 50. That's protecting you from the UVB, the burning rays, UVA, the aging rays, and the rays that cause photo damage that can lead to things like actinic keratosis and squamous cell is a 4 to 5 star. Your wide brim hat, you may even need to invest in some sun protective clothing. Try and seek the shade, particularly if you're somewhere abroad and it's hot and it's burning, that really can cause skin cancer, particularly melanoma, whereas accumulative ongoing sun damage can also cause the non-melanomas. Now, there is a wonderful charity called Changing Faces that works with a lot of skincare charities. And the aim of this charity is to help people cope with a visible difference. They provide some really amazing online resources and support, including well-being, and they offer a set of free counselling sessions for people who are really finding it hard to come to term with facial eczema that may be changing the shape, size, feel, or look at the face or the body. So this can also relate to anybody with difficult eczema that's just finding it really, really hard to cope with. And it's really important, that there is a myth of severity, and sometimes someone can appear to have quite mild facial eczema, but for that person, it's completely devastating and life-changing, because all they do is see their eczema. It's no good a healthcare professional saying, well, it's mild, it's not that bad. That's the worst thing anyone can say. You have to say to the patient, I accept and can quite understand how you're feeling, because that's how you feel about your eczema, and that's why we want to help you. So facial eczema is a visible condition, and it can have a large emotional impact and make you feel self-conscious and reduce your self-esteem. So that's why it's really important when you see healthcare professionals to maybe talk about if your mood's feeling low, or if you're really not coping with having your eczema so visible on your face. So Changing Faces is just a great charity, and if you're really suffering and feeling this way, I would urge you to contact them. They may be able to really help you in really many different ways. We also have some really good resources. We've got our Contact Dermatitis booklet, which will talk you through, again, what patch testing is, and our facial eczema fact sheet. We have fact sheets, about 45, I think, on nearly every topic you could think of, and we've still got more topics to add. So you can download fact sheets on specific areas. We've also got one eczema around the eyes, we've got one on contact, allergy, etc. So you can go to the information section, for the Contact Dermatitis booklet, you can just click the booklet session and you can download all of these for free. So that is great because my aim is always to leave a good 15 minutes for questions, and it's 18:46.
Brilliant. Right on time, Julie.
Yeah,
Okay, I'm going to kick off. We've got lots of questions, so we're going to try and get through them as quickly as we can to get all of your questions answered. But thank you very much, everyone who has written in the chat and submitted their questions. So we're going to start, Julie, with a question about dupilumab. I'm on dupilumab, and it has really helped my boy, but I have, I have a full, sorry,
body,
I can't quite read
perhaps.
this.
Body,
Yeah. Any, sorry, I'm going to start that question again. I think two people have merged together. Hang on. I'm on dupilumab, my eyes are sore. What would Julie suggest around my eyes?
Yeah, no, this is a really, really good question. And as I said, I did say at the start that we wouldn't discuss side effects of treatments in detail. But in fact, dupilumab is such an incredible breakthrough, along with other biologics and other JAK inhibitors. And then there's a new topical cream coming out. So it really is the era of eczema, I think, at the moment. There's a lot more treatment choices. So of course it's you have very severe eczema. You're given an advanced medication, which is an injection, which is given twice a month, and your body becomes a lot better. It turns off the itch very quickly, which is very exciting. But your face doesn't, and your face is slow to respond, and then facial eczema is there. And then unfortunately, for 30% of people who have dupilumab, which is a reasonably high amount, but saying that 70% don't, so we always keep the balance of the statistics, the eyes can become very sore. So I think if this does happen, it's really important to speak to your dermatology nurse who's monitoring you, and let them know as soon as you get symptoms. The dermatology nurse will speak to your dermatologist, and quite often the dermatologist may even refer you to an ophthalmologist. Ophthalmologists try and work. If it is really difficult to control this side effect and this flaring of eczema around the eyes, you may well be moved onto another therapy because it may just not be compatible. Even though it's helping your body, it might not be compatible with your face. This is something when, to calm it down, you may well need a slightly stronger steroid around your eyes, hopefully a moderate, but occasionally a strong steroid just for literally a couple of days, and just to settle it down. But it's just it's quite soul destroying because you've got something that's helping your eczema in one part of your body, but then in another part, which is the visible part, it's perhaps not. But I do stress it doesn't happen to everybody. Lots of people have dupilumab very successfully and get clearance of their facial eczema. So again, it's like anything, what suits one doesn't necessarily suit another, and side effects can also vary. So I hope that helps answer that question.
Brilliant. Thank you, Julie, and apologies for me tripping over reading that out. So we're going to go in with some more now. Can you use Protopic for facial eczema when pregnant?
Yeah, that's a good question. Often there is caution in pregnancy with all sorts of treatments. Again, within the sort of drug guidance, most drugs say not for use in pregnancy and breastfeeding, purely because, can you imagine if you were pregnant putting yourself into a clinical trial? You just wouldn't do it. So the problem is very few things are tested on women who are pregnant or breastfeeding. So really, it is up to the discretion of your healthcare professional, whether it be your GP, nurse, or dermatologist. Probably there's a bit more preference to using topical steroids in pregnancy to TCIs, but actually, generally, there's very little absorption. But I think, if you are pregnant, you do need to just double check with your healthcare professional and follow their advice. Oh, you're muted, Eleanor. Your microphone's off.
Apologies, rookie mistake. Can TCIs be used on open wounds?
Yes, it's a good question. We get this question a lot, so I'm glad you asked it. Eczema often is open skin because of the damage of eczema and the scratching. Now, eczema is an epidermal disease. So it is affecting the superficial layers of the skin. And if you don't treat the eczema, and eczema, which is flaring, can have breaks, if you avoid that area, you're probably avoiding, the furnace of the fire. So you can definitely use any topical treatment on broken skin which is inflamed, because that's eczematous skin. Saying that, the TCIs may be more likely to tingle or burn. So again, I still would say use in conjunction with topical steroids for your short course. So put out your fire, and then when your fire's out, you're left with embers, just like any bonfire. And I think the TCIs probably work better for the embers than the actual fire. So it's sort of, get control with the steroids, the short term, then keep control with something like the TCI.
Brilliant, thank you. We've had lots of questions about sunscreen and brands that are recommended. We do have a list of recommended sunscreens on our website. I've linked the pages. It's called Eczema and Sun. So if you type that into our website, you'll be able to read all about how to look after your eczema in the sun and find a list of recommended sunscreens that have been recommended to us by members of the eczema community. We can't explicitly recommend any certain brand, and we certainly don't endorse any, but please do take a look there for those that have worked well for others. So on to the next question, Julie. What's your opinion on using a probiotic cream? What can be used to restore and keep the pH of the skin right?
Yeah, well, probiotic creams probably have not been licensed as medicines. I've heard of oral probiotics, and that I'm sure there are probiotic creams around. But unfortunately, there isn't any medical evidence that putting a probiotic cream on the skin, because if you've got probiotics, if you use a probiotic, you're actually altering more your gut health rather than your skin health. And with eczema, it's very difficult to alter the whole microbiome of the skin, because your skin is literally one organ. So it's something that we haven't really seen as an emerging therapy or recommendation. This, as always, you have to be open. This may change in the future. So what was the other part of the question? Probiotic cream and pH. pH,
Yes.
yeah. Well, pH of the skin is generally much more affected by soaps and detergents. So really what you wash with, because a soap and detergent will dry out the skin and raise the pH of the skin to 8 or 9, and even hard water alone 7. But if you use an emollient all over the skin, you'll bring it down to a pH of 5.5. The thing is, when you're addressing skin pH, again, you've got to look at the whole organ. So thinking of, skin is an organ, like a heart is, like a lung is. So you have to address the whole skin, really.
Brilliant. We've had one question about recommended facial washes, but I'm going to quickly recommend that Julie said throughout the presentation you can use emollient to wash your face. And I'm going to go into the next question for you, Julie. It says, if you need to clean items that are used on the face, e.g. makeup brushes, what should they be cleaned with?
Yeah, no, it's a really good practical question, isn't it? I think it would be good to use a sort of gentle antibacterial, sort of an antimicrobial thing. So you could basically, if you're using dermal, for instance, I know we're not meant to talk products, but dermal is the only emollient that has antimicrobial in. You could just get a bowl full of water, put some of your dermal in, and wash it with something like that. I think, and then you could wash the brush out again. You could use, a tiny bit of bleach, but make sure you don't need bleach on the brush. I probably would prefer you to use something which is antimicrobial, really. I wouldn't really use things like TCP or Dettol, because they can be quite harsh. So maybe a little bit of Milton in terms of bleach rather than household bleach might work.
Brilliant. A few questions about what is a medical moisturizer, and what's the difference between a medical moisturizer and an emollient?
Yeah, no, it's always explaining terminology. I'm so sorry. There's so much to get through in the webinars. And of course, I think it was our third webinar that was all about emollient. And indeed, I did explain this. So a medical moisturizer generally is a bland moisturizer, and an emollient and moisturizer in effect, it's a bit like eczema and dermatitis, they mean the same thing. So something that will soothe the skin, but something that basically contains a few ingredients. Most emollients are paraffin based. There are a few who aren't, but a paraffin allergy is almost unknown because when you do patch testings, we use paraffin within the cases, and contact dermatologists very rarely see a complete flare to everything. But saying that, it shouldn't contain any fragrance. That's the main thing, and no other additional things. And included in fragrance actually is essential oils, because in effect, essential oils are fragrances. So something that's bland, they can have different formulations. They may be gels, flimsy ones and lotions, not so good for people with dry skin because you need an emollient that's going to repair the skin barrier. They may be creams, they may be gels, they may be ointments. People who are neurodivergent with skin sensitivity, you might do better with a spray even. But I think hopefully I've explained it. As opposed to a medical moisturizer, a cosmetic moisture perhaps would contain a lot more perfume, fragrances and essential oils and things. And perhaps the formulation might be a bit more flimsy, suited for normal skin, but not so much for eczema, where you absolutely need to repair the skin barrier. Emollients are the single most important treatment with any eczema. Yeah.
Brilliant. We've had quite a few questions about sweat irritating eczema and how to deal with facial eczema, particularly that flares up after exercise. Do you have any recommendations on how to stop that?
Yeah, I think it's really hard, because sweat has a high salt content, and it really irritates eczema to skin. And of course, it's just fantastic that you're all exercising. So it's a bit tricky, isn't it? I think you don't want to make sure you over sweat. So even though we like to use emollients regularly, if you are going to go to the gym and you know that you're going to sweat, don't use a very occlusive moisturizer, because sometimes that moisturizer can actually block pores and make it more sweaty. It's probably best, if you are feeling dry, to have a much lighter moisturizer. This is somewhere where a lotion might actually be a very good factor. And you could also keep the lotion in the fridge so it goes on cool, or actually just simply moisturized after the gym. I think if you're in the gym and you're getting hot, it might be quite a nice idea to have a sort of iced flannel that you can just just place on your face to try and stop some overheating as well. And then, of course, when you get back, have a nice emollient shower, or at least wash your face in an emollient to just immediately wash off the sweat. And again, you could take your emollient along to the gym as well.
That's great. What can you do about recurrent staph infections on the face?
Yeah, recurrent staph infection can be really, really tricky, and recurrent infection is really tricky. I think if you're really getting recurrent infections, it's really important to ask for some skin swabs. It's also really important on the face, and this is something I've seen quite a lot in my practice, as well as swabbing the skin, just swab inside the nose. Now, the other thing to do if you are getting recurrent infections is it's sometimes really useful to ask if the whole family, even people without eczema, can have their noses swabbed. Because what often happens is it's often can be the person in the family who doesn't have eczema. So, for instance, maybe there's someone in the family who is in close contact sport who's actually harboring some Staph aureus in their nose, and Staph aureus love sort of warm, moist places. They have absolutely no symptoms. They're absolutely fine. But sort of cuddling a child with eczema may just pass that staph on. I have seen that a few times. And when we've swabbed the family, it's often the person without eczema who may have the staph on their nose, and that then drives the infection. And then once you have a sort of antimicrobial nose spray, and you eradicate the Staph aureus, that works very well. And also, it's quite important to make sure that it is Staph aureus. There can be other sort of strains of bacteria, so it might be that a different antibiotic is maybe required for that infection. And I think if it is recurrent, I think that's a really good cause for actually referring, actually asking for a referral to dermatology, because it just means eczema is more complicated if it's not coping with infection. And I think it's really important that it's probably more severe and you probably need a referral to dermatology.
Yeah. Slightly over here, but I'm going to ask one more question and then we're going to round up. So thank you everyone for your wonderful questions. The 30-minute gap between Elidel and emollient, is that emollient first?
Oh yes, it's I always say it's the old chestnut. It really doesn't matter. It's a bit like the tube, you mind the gap. But actually, in truth, if it's maintenance and someone isn't flaring with steroids, I generally always say emollient bath, pat dry, steroid first, because then the flared areas often are more visible after having a short tepid bath. Have the gap and then apply the emollient. If you're applying it as a maintenance, you can do it the other way around. I think the most important thing is just to have a gap. The main reason is you don't want to mix the topical calcineurin inhibitor or the steroid and moisturizer. Not that it's going to do any harm, but what it will do is just dilute it down and it simply won't work as well. So that's the main reason. Yeah.
Thank you. Well, I think that wraps us up for today. Thank you, Julie. A really wonderful presentation as always, full of lots of great information. And thanks to everyone that's joined today. If you're new to the eczema community, welcome. It's been great to host you. Managing your eczema can be incredibly difficult at times, especially when it's on your face, but we really do hope we've been able to provide some useful information and guidance. We do have a number of downloadable fact sheets and booklets on our website about a variety of topics, but a lot relating to facial eczema. So that's on our website, which is eczema.org. They're there to help support you through the self-management of your eczema. If you want to get more involved with what we do at the National Eczema Society, you could sign up to become a member. You can sign up to receive our monthly e-newsletter too. And you can also follow us on our social channels, so where you'll hear about the latest eczema news, events and information to help you self-manage your eczema. As this is the last topic of the series, I want to say a heartfelt thank you to everyone who has joined us throughout the whole of the series. If you've only joined us towards the end, please do take a look back at our previous webinars. It's been great to hear from so many of you within the eczema community, and we're so pleased to have been able to provide you with a new form of support to help you through the self-management of your eczema. As we've said, all of our sessions have been recorded and they're available to watch again on our website. So if you type in watch again, all of our recordings will be listed on one page, so you'll be able to watch them whenever it suits you. They are also available on our YouTube channel, where you can subscribe and be the first to know when we've put a new upload on there, which is always very exciting. But I just wanted to say thanks again for joining. We will be returning with a series 2 of our Exploring Eczema webinars, so do drop me an email if there's any topics you'd like us to cover in the future, and keep your eyes peeled for news on that. But thanks again for joining, and a big thank you to Julie for all of her wonderful information and guidance. Thanks all.
Thank you very much. Thank you, everybody. Night, night. I hope it's been useful.
Thank you, Julie.
Thank you. I just end the show.